Welcome. Thank you for joining us today. I'm Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Catherine, would you like to introduce yourself?
Hello, everyone. My name is Catherine. I am the intern at Blum Patient and Family Learning Center.
Before we get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has a mute so you can hear our guest speakers today. If you have any questions for our guest speakers, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speakers will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I want to turn it over to Catherine, who will introduce you all to today's guest speakers.
Thank you. Angelina Rogers is a licensed independent clinical social worker and advocate with the HAVEN program at Mass General in Boston. Angelina has worked with survivors of intimate partner violence for the past 8 years in a variety of settings, including Boston Public Schools and hospital-based substance use treatment programs. Most recently, Angelina works as a clinical social worker and advocate at Mass General in our emergency department and with the HAVEN programs. Abby Farrand is a licensed independent clinical social worker and advocate with the HAVEN programs at Mass General. Abby has worked with survivors of IPV for 12 years and has worked at HAVEN for 9 years. In recognition of Domestic Violence Awareness Month, they join us today to give a talk on intimate partner violence and supporting individuals in a medical setting through the HAVEN program.
Thank you so much, Catherine. I'm going to take this opportunity to share my screen so we could get started. Okay, so welcome everyone. And we wanted to offer this webinar as an opportunity to acknowledge Domestic Violence Awareness Month in October. And so our presentation is titled Intimate Partner Violence and Advocacy in the Medical Setting with HAVEN.
Hello, everyone. So I'm just going to give you a little bit of an overview of what HAVEN is and what we do. Many, people who are joining us may already know what HAVEN is, and some of you, this may be new. So HAVEN is a free, voluntary, confidential program that works with survivors of intimate partner violence. And we have more recently, in the past 2 years or so, have been working on expanding our services to provide support to survivors of sexual violence and sexual assault outside the context of an intimate partner relationship. Our services are offered are multilingual, by bilingual and multilingual staff who are also bicultural. We work from an empowerment model, and really what that means is that we want to empower patients and clients to make decisions about their lives, and by giving them information about resources available or information about safety, and help them make choices and feel that they have some sort of control and power in their own life. We work from a trauma-informed lens, as we acknowledge and know that everybody we're working with is either currently or has experienced trauma And so we, keep that in mind always when we're working with our patient population and as, we kind of work throughout the hospital. So what our services look like? So we provide advocacy and counseling. We have support groups, kind of at various times throughout the year. We talk about safety planning with people. We provide a lot of referrals to other agencies or resources within the community, kind of depending on people's situations. We have a legal partnership with Casamirna, which is a domestic violence program in Boston, where we're able to provide free legal support to survivors. So we're very fortunate that we've had that partnership going on for quite a while now. We also accompany patients to various places in the community or within the hospital. The primary place that we accompany people is court. But we also could come to medical appointments. Sometimes, there may be other things that are happening in the community where somebody would like us to accompany them. And what we do as for providers within the Mass General hospital system is we provide consultation about cases. We can offer advice, especially if somebody's not interested in talking to us, but as a provider, you're looking for some support. We also are able to debrief difficult cases. We know these cases and situations can be really challenging as providers, and we are, available to talk through, think about could we have done things differently, done things better, or just some emotional support about how challenging sometimes it is to sit with the information or sit with the situation. We also are happy to provide referrals to different resources to providers. Sometimes patients don't want to meet with us for various reasons, but we're happy to pass along the information so that you can pass that information along to your patients. And then we do a lot of trainings just like this, or we do trainings within departments throughout the hospital. But we try to, make ourselves available if there are especially specific areas that feel like they would really benefit from having us come and talk more to a bigger group or to your staff. We have 3 different locations where we have advocates. So we're located at the main hospital in Boston, where we have advocates. And then we also are at the MGH Revere Health Center and the MGH Chelsea Health Center. So just to kind of center us is about, we're going to primarily we'll be focusing on intimate partner violence. And so just grounding us in what kind of terms we'll be using today and what terms we as Haven use. And so and just when we're working with patients. So, it's important regardless of the patient. And I think that, this is something that as Mass General has been working towards is, using the correct pronouns for folks and the patients and what they would like to be, whether it's their name, how they would like to be identified, or what pronoun that they are would like to use. And so, just asking folks how they would like to be addressed, and what's their preferred name, what pronouns do they use? I think that's important regardless of who you're working with. Also, we're going to be talking specifically about intimate partner violence, but also wanting to make sure that, we acknowledge that relationships happen on a spectrum. And so there are, from healthy relationships to unhealthy relationships to abusive relationships. So, at Haven, we want everybody to be in healthy relationships. We believe that everyone deserves to be in a healthy relationship. We know that a lot of folks are in unhealthy relationships. And sometimes it's hard to differentiate, is it unhealthy or is it an abusive relationship? And hopefully we can sort through a little bit of that today, but that many people are in unhealthy situations and unhealthy dynamics in their relationship. And that doesn't always mean that it's an abusive relationship. And just, domestic violence, I think, is probably the most common term that is used, or is very well known. And domestic violence is a really broad term. And so I think that sometimes that can be inclusive of any kind of violence that is happening at home. So that's family violence or a roommate, or even sometimes just in where you're living and feel it, that it's just considered domestic violence. But that is also a term, such as we're in Domestic Violence Awareness Month, and, is a term that's often used interchangeably with intimate partner violence. And so, for the purposes of today, we're really focusing, and of how Haven and our expertise is really about intimate partner violence, intimate partner abuse, partner abuse. Those are kind of three different terms that, again, can be used interchangeably. And that really what it is, adding to this part where we're really talking about those intimate relationships in our life, that person that you are in in a relationship with, and not a family member or maybe a roommate or that. And we use the term partner as to not assume how somebody defines their relationship. We don't or how they refer to their partner or significant other. I think it's also, interesting to the difference between using violence versus abuse, intimate partner abuse. We work with a lot of folks who don't experience physical violence, and so they feel like intimate partner violence, like I'm not in a violent relationship, but still may be experiencing abuse because there's a control dynamic or there is emotional abuse happening. And so that term intimate partner abuse sometimes feels like it describes their relationship better. Um and and so, I think that terminology matters, and it's feels like exclusive for some, but if we use certain terms, those don't feel like it includes some people, or some survivors feel like that doesn't reflect my experience. So, we just kind of naming that you may hear some of those different terms, and that they are used interchangeably and that they mean relatively the same thing. But for Haven, we typically use either intimate partner violence or intimate partner abuse to describe what we're going to be talking about. Also, sometimes, especially, providers, when you're meeting somebody and you're hearing about their relationship, the term intimate partner violence or intimate partner abuse maybe feel too much for somebody. They're not in the place of labeling that as an abusive relationship. So using terms like relationship with safety concerns feels sometimes like a term that people can, relate to better, or it feels less intimidating, and it feels like, okay, I'm not labeling my relationship as abusive, but I do know that I don't feel safe all the time in this relationship. Um, Victim versus survivor, we use the term survivor to describe patients, to describe people who are in abusive relationships. But often, for some people, the word victim feels like it describes their experience and what they, how they identify of what's going on. It also is a term that's often used in the legal system, there is a victim and a perpetrator. And so really, mirroring what somebody feels best and what feels most comfortable. And sometimes, I've worked with people who feel like I felt like a victim at one point, and then I've transitioned into feeling like a survivor after a period of time. When we're talking about people who use abuse, the term batterer has been used, abuser, perpetrator, again, which is typically a legal term. But we've really tried to transition away from using those terms and talk about a person who uses abuse or a person who uses abusive behaviors. Is that, that person is not 100% defined by their behavior, and that they, using that person first language. Again, really mirroring the language of the survivors that we work with, because sometimes that is not a term that lands with folks of what they want to use. So, sometimes I just ask, or if somebody's talking about their partner in a certain way, kind of using that language. There are programs for people who use abuse, and those used to be called batterer intervention programs or abuser education programs, and those have now are called intimate partner abuse education programs. We won't really focus on those today, what that looks like, but if you're interested in more, what that can look like and what it looks like for their treatment for folks who use abuse and are abusive, let us know. And just so we know is that, no one is illegal. And so we're not talking about illegal immigrants or using that kind of language. We're talking about people who are undocumented or folks with or without status. So, the definition that Haven uses to work from about intimate partner violence is, this is the definition that we use. And so I think that the important pieces to highlight are that this is about a pattern of coercive control. And all of the control is um, the purpose of that is to first establish and then maintain power and control over another person. And all the different tactics that are used for that are listed here, and we'll talk kind of more in depth what that can look like. But really a big piece of this is that it is a pattern. It is not about a one-time incident that happens. Of course, we are not advocating for any kind of violence in people's relationships and want people to be safe. But there may be an incident that happens that's a one-time thing, and there is no pattern happening over time. There is no control dynamic in the relationship where one person has control over the other person. And so those we would look at as these unhealthy relationships and have maybe safety concerns, but would not necessarily fall under the category of an abusive relationship. And thinking about all these tactics, again, are about establishing and maintaining control over your intimate partner.
Hey, thank you, Abby. Who is affected? So intimate partner violence crosses all boundaries of culture, race, class, religion, age, gender, sexuality, and we really see that reflective of our patient population here at the Haven program. There are groups that are particularly vulnerable, which include folks who are newly arrived, immigrants, refugees, people with disabilities. They face additional risks, and this has to do with societal factors that really reinforce the stratification of our society and power and control, and what that looks like both on a societal and institutional level that plays down into those individual relationships and dynamics. 1 in 3 women and 1 in 4 men have experienced some form of physical violence by an intimate partner. We support women, men, folks who are non-binary, and it is perhaps a misconception that men do not experience violence, and that while they experience violence, maybe not as frequently as women do, they are experiencing violence. And there are some cultural norms and societal expectations that perhaps maybe aren't talked about or aren't as socially accepted. 25 to 33% of LGBTQ plus people experience abuse by a partner. It is estimated that 1 out of 4 LGBTQ plus youth will experience abuse from a dating partner. And so Haven supports a few programs. I can't speak directly to them because I am not a participant in them, but where we provide education and support to students in high school to really provide education around what is a healthy relationship and what is not, and power and control and coercive control, and those dynamics that maybe aren't talked about enough, especially as young people are engaging in intimate relationships. And abuse can occur at any stage of someone's life. So from teen dating violence, like I just spoke about, to elder intimate partner abuse, which we see often. And it's important just to acknowledge that it doesn't discriminate, right? We see folks from all different walks of life, while folks are with marginalized identities have perhaps some specific vulnerabilities to abuse. It really happens across the lifespan and across the sociocultural spectrum. And so I wanted to make sure I name that. The other thing that's important to name in here that's not added is the fact that folks who English is their second language also have a particular vulnerability to experiencing abuse. And I think it's wonderful that we have advocates that are bicultural and bilingual, multilingual, who can really support our patients and support our providers in ensuring that we are assessing and that we are providing support to folks who English is not their first language and perhaps already have a interpreter or some other dynamic they're trying to translate and navigate in this medical setting, and making sure that we are able to provide support to that, right? And have a keen eye to using interpreter services to be able to complete these assessments, and not using family members perhaps because of their risk of not being able to really provide true information at times. Okay, sorry. Barriers to leaving. And so like Abby talked about, there are many barriers that survivors may face when thinking about leaving a relationship with abuse. And I think Abby talked about how that can be really difficult in a medical setting, especially as we're attempting to discharge a patient and we are feeling really worried about their safety, and we are holding that for them. I think it's important to talk about the barriers to leaving because there's a lot of shame that can come to survivors and that survivors experience around their decisions perhaps not to leave. And I think we all want folks to be in healthy, supportive, safe relationships. And that is really hard for many folks, and it's really difficult to leave. And so some of the barriers to leaving are love, right? No one gets into a relationship expecting to experience abuse. You know, we can hold two things at the same time. There are folks who are incredibly loving, incredibly good fathers and mothers and parents, and co-parents perhaps, but have and use abuse. And so it can be really difficult to really make those hard decisions when there are so many good things. And then there's the safety concern and this abusive piece. Housing, as we know, it is really difficult to be able to access safe housing, and in particular, really difficult to live independently and to live as a single person if you have children. And so housing and financial stability and those things are really complicated factors that survivors have to consider when they are thinking about leaving, right? Safety, we know, and research suggests that leaving can be one of the most dangerous times for a survivor, and their safety can be most impacted as they are deciding to leave. And so really considering safety during that time, not, being thoughtful as survivors are able to consider their safety and to plan for these things, to think about other supportive people in their lives that could help support this transition, and working with an advocate to really consider the safety concerns that could present, and really, trusting our survivors. I think Abby spoke wonderfully to our model, but it's really just, survivors are experts on their own lives, and they are keenly aware of their safety concerns. And we have to, and we do respect their decisions. What makes most sense for them, they know that. better than we will ever know that. And just really trying to walk with them with that and thinking about their safety along the way. Mental health, shame, children, right? What does it mean to have to leave, and how will that impact my kids? Is a conversation that many survivors have with us all the time. And how do we navigate those complicated dynamics? Language barriers, as I talked about in the last slide, misconceptions. I think there's just this common misconception that folks who experience violence should just leave. Why don't they just leave? It's a question that we get asked often by providers and community members, and that survivors really hear, right? Well, why don't I just leave? I feel like people think differently of me because I'm not leaving. And how can I receive support while maintaining this relationship if I'm not going to ultimately leave? The Haven program really supports survivors in understanding that everyone's situation is different and it may not be safe for folks to leave. And so supporting survivors in considering their safety and becoming safer if maintaining the relationship is what is required for them. Cultural factors, divorce, leaving, not living together, not sleeping in the same room. There are a variety of cultural factors in society's expectations of what relationships or marriages should look like, and it really plays into the survivor's decision-making process. And how will their communities perceive them, right? What feels okay to them based on what they have been taught generationally, perhaps. Powerlessness, immigration status, right? If folks are undocumented or are without status, it can be really difficult to make the decision to leave for a variety of reasons, right? Receiving support, perhaps the potential at receiving status, and considering what that could look like for themselves, for their safety. Hope. I think the biggest one is hope. Many of the survivors that we work with, they have hope. They got into these relationships really hopeful. They got into these relationships expecting perhaps it to be different and not to have experienced abuse like this, and hope that something will change in the future. And we sit with folks in that. I think it's important, like we said, is to meet survivors where they're at in this process. It's really difficult, and meeting them where they're at and giving them all of the choice over their own life in an otherwise unhealthy and perhaps controlling dynamic can be really supportive and can really be an empowerment to them to be able to make the best decisions that they can and to hold hope with them. And then the failures of the systems put in place to help protect them. I think as Haven advocates, we work both with patients and providers, but also within the context of our communities. Like Abby said, we provide court accompaniment. We have a legal advocacy arm to our program where we liaise with Casa Mirna to be able to get legal consultation for the survivors that we work with. And we interface with housing, we interface with Department of Transitional Assistance, with school systems and divorce attorneys and court systems, so on and so forth, hospitals and doctors' offices. And I think it's important to name that many of the systems that have been put in place are not always survivor-centered, right? They don't always consider the multitude of what it looks like to live in these relationships, right? To live in the world with concerns for your safety. And all of the different systems and the criteria that are put in place to be able to access resources don't always take in consideration survivor safety and the complicated nature of these situations. And so I think it's important to name that we see this often, and we work with survivors through this. And I think advocacy is really important in this regard, where we can advocate and provide education on folks' behalf and with folks, but it can be really difficult to access the necessities with the way that our systems currently operate. Okay, so when we are talking about abuse, there are a variety of types of abuse. So physical abuse, which you can imagine is, you know, anything that is physically violent, anything that happens to your body, or that is a threat to happen to your body, right, is physical abuse. Sexual abuse is something that we see both within the context of intimate partner relationships, but also, like Abby said, expanding our services to support survivors who have experienced sexual assault and sexual violence outside of the context of intimate partner relationships. Emotional abuse, which can look like name calling and manipulation. Same with verbal abuse. It can look like, perhaps damaging someone's image in the society, right, and in their communities, and sharing information that is untrue, sharing protected information that should not be shared with anyone else. And then financial abuse, which can look like withholding finances. It can look like having control over all of the finances and not allowing the survivor to access any of their finances, cannot share finances, have to ask for finances, withhold finances as a means to power and control. It can also look like, when we think about financial situations, health insurance is one thing that comes to mind, that we see often as survivors who need health insurance both for themselves and or for their children, and partners who use abuse, using this as a way to continue to uphold power and control in the relationship. So either saying, we're not going to, you do not get access to health insurance, or if you leave, I will not give you health insurance. And then survivors really needing to contend with that real idea. Will I not have health insurance? Will my child who has medical complexities not be able to access medical care that they need? And then other cultural, including religious, I think it's important to name that in a variety of different religions and contexts, it's not uncommon for folks to experience abuse in some of those settings. While those settings can be so hopeful and uplifting and wonderful institutions that build community and a variety of other things, there are times in which sometimes the text can be used as a form of abuse and manipulation. And it's not uncommon for us to contend with these complex, big questions with survivors around, what does this mean? And how can we perhaps interpret it differently than that? And then digital, I think technological abuse is really important for us to talk about, because it's something that really happens. Monitoring phone calls and text messages, and perhaps surveillance with cameras around the house, trackers on vehicles, and sharing of perhaps digital images and pornography that should not be shared. And so it's important to name that in the sort of digital technological age, abuse is really present on those mediums. And it's important to just consider as we are supporting survivors who have a electronic medical record, and perhaps their partner and the person who uses abuse has access to it. And what do we document in the medical record is really important and can impact someone's overall safety in a way that we maybe wouldn't otherwise have thought about or been as concerned about when there wasn't as much access to these things. And so just being thoughtful, right? I think it's important to just name, as we are medical providers and we have these systems in which we're required to document, what are we documenting? How are we doing it? And how is it reflective of what the patient and or survivor feels is safest to them? And asking them those questions, I think, is really crucial in this, because they, like we said, are the expert in their lives and will be able to share with us, yes, my partner does have access to my medical record. I am disclosing this information to you, not because I I didn't know that you were going to document this. And what does it mean for you to document this? And do you have to? And if you have to, what can that look like so that both you maintain as providers your role in documentation, and also we maintain and work with patients collaboratively around their overall safety in that.
So now just kind of shifting a little bit and thinking about what does the Haven model in the medical setting look like, and what does advocacy look like in the community, and more like a community-based domestic violence program. Some of you may be familiar with the idea of community-based domestic violence programs, and we are fortunate in Massachusetts, and especially in the Boston area, that pretty much all of the hospitals have some kind of intimate partner violence program at their hospital. And I think that one thing, and I can say I've worked in both settings. I've worked at a community-based organization and also at the hospital, and both have benefits, and both have things that make it more challenging. And so just kind of highlighting what Haven does, or how it works in the medical system. Of course, we have access to interpreter services, which is huge. That is not something always, is available in the community. So it feels like we really can hopefully support survivors who who show up at, in any of their language needs. And I think that we also, it's this unique opportunity to engage with patients, is that, if you're going to domestic violence program, or in the community, first of all, it may be just a standalone, physical place that you're going that doesn't feel safe, because it's like, okay, so like Angelina talked about in terms of abuse, it's like somebody may be tracking me, and if I go to that location, like they know where I'm going, and that doesn't feel safe. Or that I'm just not ready to use the words like I'm in an abusive relationship, and this is the kind of support that I need. And so, but when people come to the hospital, whether it's for a medical appointment, or they come because they have a medical emergency and they're coming to seek care, it's a unique opportunity to talk about safety in people's lives. And sometimes it may be the only time that somebody is alone, and they're not with their partner, is when they come to their annual appointment at their primary care doctor, or they came to the emergency room for something and they are, they're alone. And that, next we're going to talk about screening, but that again, these are the opportunities that have been created because of the setting that they're in, and that they can access support while they're at the hospital. And I think that there is this real, benefit of Haven being embedded at the hospital, is that we can, work in an interdisciplinary team, that we cover the entire hospital. Inpatient, outpatient, walk in, like and so we're able to communicate with providers, and who maybe have a relationship with a patient who is concerned about, or just it's hard to take that first step and say like, this is what's going on. But when a provider can say, you know what, but we know people here at Haven, or I can, show you where their office is. And then that maybe feels like the warm handoff, the bridge to services that really that allows somebody to access that. And sometimes, we also work with obviously people who have a lot of complex medical needs. And so it's helpful that, we can communicate with providers, and we can, feel like we're all coordinating care, and that we're not all siloed and all working on different things. Um, And I think that, we are based in the community to an extent, in terms of, with the health centers, and they definitely have a presence in those communities that they cover. At our Revere Health Center, they also, like Angelina mentioned, the advocates there go to the health, they teach at the health classes at Revere High School to talk about healthy relationships, and so, building those connections. But in the community setting and community domestic violence programs, they often are smaller organizations, but they're more embedded in the community. I've only, when I've been at Haven, I've worked at the main hospital. And so it's really hard to be completely embedded in the, Boston community, in terms of partnerships, like with the police, because we maybe see patients who come from all over Boston or not even in Boston. So we don't have those partnerships in the same way that community organizations oftentimes, they have advocates who sit at the police station, or sit at the courthouses in those communities. Also, sometimes community domestic violence programs have specific, like they have housing advocates who help people find housing, or they might have, different resources to, specific housing that's available in that community. A lot of them have residential programs, meaning shelters, and that is not something that Haven has. But both types of programs, we all provide advocacy, counseling, support groups, and really can help really help navigate, systems. And so you may meet with patients who, you ask them and it's like, oh, they actually are connected to a program in the community, or, and already have that relationship. But we also can help you kind of sort through that. Now, talking about screening, so I think, screening is an important thing, an important role of providers is, and then it, oftentimes an expectation to screen patients and ask about safety at home. And I think the important part about when you're screening a patient is wanting to really set this stage is important, is that people don't want to feel targeted. They don't want to feel like, oh, is there something about me, or that that's why you're asking me these questions, or you think something about me, or I've said something, or the way I look. It's like really that this is what we ask all of our patients. We ask all of our patients these questions because we know that people experience unsafe situations in their relationships, or we know that domestic violence is really common and it impacts your health. And so that's why we ask these questions. And for most people, that it's like, great, you say that, you ask your questions, and for many people it's no. And then you're moving on to your next, assessment question. But it also just shows that we value, um, people, we want to know about people's relationships. We want to know about safety in people's relationships. And so that's why we're asking these questions. And we have up here is just a few examples of how you can ask questions. I think it's really important to ask more specific questions. Oftentimes people use like a general question, do you feel safe at home? And that can be a great question to just open a conversation about safety, but safety could mean a lot of different things. And so somebody could not feel safe at home, and that could be because they live in an unsafe community, and so that doesn't feel safe, or because things are physically, broken in their home, like the stairs are broken, in the hallway, or it doesn't have, a railing, and I don't feel like I can walk up and down the stairs. So, it can be a good opening question, but doesn't always lead to about your actual relationship. So, you know, encouraging you to ask, do you ever feel unsafe or afraid of your partner? And then you can kind of ask some more specific questions if that is the case. And so I think what's important, and I think oftentimes what we hear from providers is there is a level of, they feel they have figured out like what kind of questions to ask, or they don't ask the questions, not because they don't know how to, but it's okay, if I ask this question, is what do I do if somebody says yes? This is what's happening. I don't know what to say next. And so, really the biggest intervention you can offer to a patient who, after you've screened, and if they say yes, is validating what they've said. Your job is not to fix their situation. Your job is not to have all of the answers about what this person can do. The initial response really is about offering support and validation, and that you heard them, you believe them. And so validating, I'm so sorry that this has been your experience. You are not alone. I have seen other patients in these same situations. And then you can, and then that next intervention is really offering that there is support. Would you like to talk to somebody else about this? We have a program here at Mass General who with advocates who work with you who in similar situations, just letting them know and it's okay if people aren't ready or wanting that in that moment, but just offering that and knowing that there is a resource available. And that you can offer to give that to somebody, if they'd like to take it, or would you, and I'll talk about how you refer, or we'll talk about that next. But I think it's important we believe survivors, and it's important that you as providers validate somebody in believing them. We hear a lot from survivors on the other end, both the good and bad experiences they have with providers. Meaning, we know when a provider offers that support and believes them, and this feels like this is the first time anybody has believed me and what I'm saying. And then we also hear situations where somebody discloses what's going on and providers don't believe them, or they're dismissive of the situation, or maybe it's, your own discomfort with how to respond or what to do with that, and kind of brushing it off and moving on. And so knowing that just a couple of validating statements means a lot. And we get to hear that as Haven advocates on the other side as feedback. Like I said, both positive and negative.
Okay, so when referring to Haven, we have many different ways to refer to us. And so if the patient opts for Haven to call them, so as you are offering these services, like Abby said, do you want to talk to someone about this? Or, allowing them to also make outreach to us is an important part of this. There's many folks who are grateful for the information, however, for a variety of reasons, are not yet ready to have a conversation with us, but then do, and we see them follow up later when they are in a position and are ready to have these conversations and to consider beginning that work. And so it's important to explain Haven services, right? If the patient opts for Haven to call them and says, yes, we would like to, I would like to talk to someone, explain Haven services. Oftentimes, if you are inpatient or in the hospital, you could also page us, which is another available way to get in touch with us. We always have an advocate on call Monday through Friday, 8:30 a.m. to 5 p.m., who is available as time allows to be able to meet with people in the hospital. But I think it's important to explain our services, say that we offer confidential, offer empowerment model, meeting survivors where they're at support. What that looks like is we provide advocacy, both within the medical system and in the community, and in the court system in general. We provide education around intimate partner violence. We provide education around abuse, control, manipulation, what that looks like. And what does a healthy relationship look like? And how do I consider red flags or consider some of these behaviors in my relationship that make me feel a little uncomfortable, but I haven't really been able to decide what that is. We support patients in that process. It's really helpful for us and for the patient in general for you to be able to receive a safe phone number for them and a mode of safe contact. And so we always ask providers to ask patients if they are interested in meeting with Haven, to ask them if it is safe for us to call them, and if it's safe for us to leave a voicemail. And if it's not, we are creative and flexible in getting in contact with patients. They can provide an email address, they can provide a specific time to call. You can provide them with our number and let them know that when they are safe to call, they can call us directly, and then we will give them a call back. Ask for permission for Haven to provide an outreach call. Let them know that if, since they are interested in services, Haven would make an outreach call. Does that feel okay to you? Are you comfortable with that? Is there any safety concerns to consider for Haven to be calling you? And just so you know, as providers, which I think can be helpful in letting patients know, is that when we call, our number often comes up as blocked and unknown. It's a layer of safety to protect safety that we do, so that should their partner who uses abuse have access to their phone, it doesn't come up as the Haven program. It comes up as unknown number, blocked caller, depending on your service. And so it also can be a little bit confusing for survivors. And so they ultimately oftentimes appreciate it. And after that first phone call, we have conversations with them around whether or not this makes sense for them, and we can unblock our calling. But just so that they know, so that they can pick up the phone, that we would be calling blocked, and that we would leave a message if it was safe. If it was not safe, we would call back again. And then you can send a referral. Like I just said, we are available by page. We are available by email, online. On our webpage, there is a section to fill out for patients to self-refer or for referrals to be made. By phone, like I said, we have advocates available Monday through Friday, and we have a phone line that they can call, both the Boston Haven line, the Chelsea Haven line, and the Revere Haven line. And then you can place an inpatient or outpatient referral through Epic. And again, if the patient opts to call Haven themselves, explain Haven services again, provide our contact information. If anyone needs any brochures or pamphlets, please let us know in the chat, and we will be sure to try to get some to you to provide to patients. We also have nail files with our number on them that are a helpful vehicle for information that I think can be a little sneakier and more private, so that it doesn't create a safety concern. And patient calls if and when they are ready. There are many patients who are in positions where it's not safe for them, or they cannot engage right now. And that doesn't mean they didn't hear you when you validated their disclosure, when you provided them with information. And the hope is that they felt heard, they felt believed, and they knew that there is support when and if they are ready to receive it. And so that's what we hope for survivors to be able to feel should they disclose. And we want them to have that information and give them the choice to be able to make outreach to us and to decide when it's a good time for them, because like I said, they are the experts, and they know, and they will and have reached out later if it's not in that moment. Okay, I'm having a little bit of technical difficulties.
I think that is the rest of the slide, or the next one is, just our references. And then I think any questions that people have, if you want to put them in the chat. I saw that there's one about sending our I guess the resources, maybe just specifying, do you want just some of our like brochures and all of our materials for the spiritual care department? Okay, yes, we can definitely make sure that you have those. And then, yeah, if just there are, I know we only have a few minutes left, so if there are any questions, feel free to put them in the chat, or you guys, people can also reach out to us.
Thank you, Angelina and Abby. Regarding your services, do you ever offer in-person services? For instance, can someone visit you in person, or do you offer them virtually through, Zoom, for instance?
Yes, so we offer both in person, virtual over Zoom, and also over the phone. We try to be as flexible as possible, recognizing that all of our survivors' experiences are really different, and their opportunities to have conversations with us could look really different. And we want to provide a variety of different mediums in which they can connect with us. And so, yeah. And sometimes people choose to do a little bit of both. Sometimes they will meet with us over Zoom or over the phone, and then perhaps once a month decide that they would like to come in person, or if they were at a doctor's appointment, stop in and be able to see us.
How about in a public location where they might feel safe?
We don't typically do that. That I would say, yeah. But we often will talk to people about safety, and like this is one of the benefits of being at a big hospital is that you can say, somebody may say, "Oh, I'm going to a doctor's appointment," and that feels, and we can talk through that with someone. But that they could say that and be anywhere in the hospital, so that's one part where the cover of a big institution can be helpful safety wise. And I guess just to add to the meeting, what Angelina said is also we meet with people. It could be one time, and then it could be, kind of we can meet with somebody every week, that it's not, we don't have a really specific set, like this is the amount of times we meet with someone, or the frequency wise, typically I'd say once a week is the most frequent, but sometimes it's once a month. It just really, there's a lot of flexibility in the how often or frequent we meet with someone.
Mm-hmm.
Thank you. And are any advocates available outside your regular office hours for any urgent, situation?
We do not have our advocates available, our specific Haven advocates available, but I will add that we have 24/7 social work coverage who would be able to provide at least immediate support, crisis intervention, and safety planning to folks who present to the emergency department and need support on after hours. And our supervisor is available for support of those social workers should they need it or have any questions around how to best support a survivor after hours.
Thank you. And does one need to be an MGH patient in order to access your services, or is it open to the general public?
So you have to be an MGH patient, and you do not have to have a primary care doctor. I know that sometimes is the access point to especially therapy or psychiatry services. So it doesn't have to be a primary care doctor, but you have to be a patient of, and get some sort of medical care. And it has to be at Mass General. So as opposed to, it's not MGB. But places like the Brigham has a program. So we would, if somebody gets their medical care there, we would refer them to a program within the hospital system that they get their medical care.
Thank you. We have one final question. Are there any online resources that you recommend for someone to learn more about, healthy relationships, signs to look out for regarding healthy relationships, and resources for support?
Yeah.
Go ahead.
I guess I was just going to share that a lot of the community, well, please, I welcome you to look at our webpage. We have some general information there. If you go on the MGH website and social service and then to the Haven department, there's some general information there. But I would just name that generally the community-based agencies also have a lot of information. Depending on where you're located, there's different sort of catchment areas for these community-based agencies. And there's a lot of information that is shared on their web pages and resources that are specific to your area. And then, which Abby, I'm sure you would share, but then Jane Doe is another really helpful resource, and any coalition against domestic violence. Abby, I want to turn it over to you because I think you could speak more to those.
Yeah, if you just look at, I would say, so Jane Doe is the Massachusetts Coalition Against Domestic and Sexual Violence. And so if you Googled that, they are a great resource, have lots of information, just educational information about relationships, about domestic violence, about resources. So I would say they're a great, or the National Domestic Violence Hotline, which you can, again, like has a web page and, could look up lots of helpful information.
Thank you so much. And I believe that's all the time that we have for today. Angelina, Abby, thank you so much for joining us today. All the resources that were extremely helpful.
Thank you so much. Thanks
you.
everyone for attending.
And for everyone who joined, thank you so much. As I had mentioned, today's session is being recorded. It'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Take care.